Hi, everyone. My name's Ankur. I'm a dentist. I've been a dentist for about 20 years, 21 years. And I want to make sure that before I start that I recognize the fact that it's a Monday, it's the evening, it's probably nice outside wherever you are living, and that sitting in front of your computer listening to CE might not be the top of your list. And I understand that, I respect it, and I want to make sure that the content that I provide you today is useful, that you feel like when you go to work tomorrow and you see patients tomorrow that you'll actually have some uh, skills and some knowledge that you gained. And so thanks so much for having me. A big thanks to Catapult for hosting this webinar, and to Kettenbach Dental. Kettenbach sponsored this webinar. Um, I absolutely love their products. I use their cement. I use their impression materials. I'll be talking primarily about one particular product, but I find that Kettenbach products are just outstanding and they are inexpensive. And so I definitely want to make sure that everybody who doesn't already use them, just keep them in mind. So I want you to look at this photo right here. And I don't think that it's outside the realm of possibility that tomorrow, when you are at work and you go in for, say, you go and see a new patient, that new patient looks something like this. And if you were like me, the thing that would jump out at you is periodontal disease. You'd be like, "Whoa, dude, your gums are gross. We got to do something about that." But then this small part of you, a lesser part of you, will say, wait a second, what's like, there's other things going on here. And so you might say something along the lines of, I need to make you a bite splint because I fear that you clench and grind your teeth and you're causing some damage. And hopefully the patient will be like, all right, cool. So I need this gum disease therapy and this bite splint therapy that you're talking about. And then I might say, so are you experiencing any issues with your jaw? And in my head, when I ask that question, I'm just praying that they're like, no, not really. No, I don't know. I mean, so my jaw's fine with me. And I'm like, oh, good. Oh, good. Oh, thank goodness. Because I really don't know how to help you. And I've been a dentist for 2 freaking decades. And my only help for a person who has clicking and popping and some weird limitations with function was always, let me make you a bite splint and just keep my fingers crossed. And that's always frustrated me. That lack of knowledge has always frustrated me. And so over the years, for these last 2 decades, um, I realized, like, if if this patient is 38 years old and they're already exhibiting so much enamel loss, okay? All of these mandibular incisors, they've lost all that incisal enamel. That molar on the lower right, number 30, that cusp tip has been flattened out. They've lost that enamel. And then more than likely, probably these crowns that the patient has on the lower left is probably because of some type of issue that was exacerbated by their clenching and grinding. And the question is this, if they're 38, and let's say they're going to live to be 88, they got 50 years left, and we don't intervene, what's going to happen to this patient? And I think all of you know the answer because you have your 70 and 80-year-old patients who have had some type of occlusal or TMJ dysfunction, and their teeth have over time just become more and more prone to problems. And I feel like if I just did dentistry the way that I learned how to be a dentist, and that is, let me make you a bite splint, even though I have no idea if you're going to wear it, or I have no idea if you're going to accept it. And then over the years, you're just going to go through the sequence of crown, root canal, extraction, and then edentulous. That's kind of how I've done dentistry for 20 years. Just watch you get old and go through this slow, insidious process, crown, root canal, extraction, edentulation. And that's something that I would want to stop now. And the answer cannot be, let me just recommend a night guard and hope that you wear it, or hope that you, at one point, hope that you wear it or hope that you accept it. Okay. So I started attending TMJ lectures. Now, this is 2 decades worth of TMJ lectures. I've gone to a lot of TMJ courses. And this is how it goes. Let me just tell you what you will learn if you go to most TMJ lectures. Ready? The person will spend a lot of time talking about things like the pterygoid muscles and the capsule and the retrodiscal tissue, the muscles of mastication, the elevator muscles. They're going to define what maximum intercuspation is, what centric occlusion, centric relation, what displacement is, what reduction is. Those definitions are going to be well established at any of these courses, and that's great. That's good. I mean, we're all dentists. We should have some baseline set of knowledge, and understanding what all of that stuff is great. And then at some point, you might get some crazy definition of what CR is. Now, when I graduated dental school and I did my residency, I had a particular attending at my residency that said that centric relation is the position of the condyle in which it is closest to the highest, the uppermost slope of the articular eminence, or something like that. And I wrote it down and I memorized it. And then I went back to like doing dentistry, and I was like, what is that knowledge even for? Like, why do I even have this knowledge of a bunch of these words, and I have no effing clue how to get that person into that position and why I would even want to get that person into that position? That was so incredibly frustrating for me. And then at one of these courses, they always say, guide the person into centric relation. Guide them in, just guide them in it. Just guide them into centric relation. Oh, they have jaw problems. Oh, you want to do some equilibration? You want to do some reconstruction? Well, first guide them into CR.
Okay, ready? Okay, open front. Okay, now bite down. Okay, now open. Okay, now relax your jaw. Relax your jaw. Relax your jaw. Try to make your jaw. Try to make your jaw relax. Okay, leave your head down. Okay, now let your jaw relax. No, like relax it. Like let me.
Dude, I didn't do that on purpose. It wasn't like I told Millie to sit in the chair and be frustrating and be an annoying patient who wouldn't relax their jaw. The reason that I took this video is because I wanted to see if I could manipulate her into CR. And I couldn't. On my own dental assistant, I couldn't. Now here I'm going to these classes, and these classes are telling me guide your patients into CR because you need to somehow be able to create a predictable bite. Now, I am a believer in CR, and I will explain why as we go through this lecture. But there has to be something beyond guiding a person into CR. Personally, I feel that some of the TMJ knowledge that I've gained over the years is a bit condescending, because I sometimes kind of feel like LeBron James can't really teach me how to dunk, because all he's going to do is like use his amazing athleticism to dunk. And then he's like this, see, like this. And I realize maybe there are people that are on this call who can guide people into CR, who are just, they understand they understand the importance of getting the jaw and the articular eminence, the condyle and the articular eminence to get in the right position. But I'm too stupid and I'm too untalented. And I want to make sure that the members of the audience here that are like me, that you have at least some knowledge that you can take back to your class. And then at these TMJ lectures, I get really unrealistic expectations regarding an articulator and a face bow. I have been to a course before that said, if you do any indirect restoration, meaning even a single crown, you should put the person in a face bow and an articulator. And I was sitting there thinking like, yeah, but it's like a lot easier to take a triple tray or take a scan or something like that. Putting a person in a face-bone articulator, in my opinion, is just not realistic for my type of dentistry. And then at the end of these TMJ lectures, they always show absolutely beautiful full mouth reconstruction cases. What I want to do today is make sure that you all understand that I do full mouth reconstruction cases. I do full mouth reconstruction cases in CR. I do equilibration, trying to lessen the gap between centric relation and centric occlusion. I do all of that, but I'm in no way a master at this. I feel like I learned some very pragmatic application from certain people who I'll talk about later today. And I just want to make sure I convey the most pragmatic stuff relating to TMJ. Okay. So after 20 years of attending all these classes, being confused, trying to memorize what CR was, I still found large cases very intimidating. See, this guy right over here, because of whatever reason, maybe it's because my office has a lot of good Google reviews, or maybe because this guy's coworker is a patient of mine, and this coworker is like, yeah, go to Gupta. Gupta really knows what he's doing. This guy, he wanted me to fix his mouth. And the thing is, I found that very intimidating. And frankly, I shouldn't. Frankly, I should know at least what are the steps that I can take in order to at least have some degree of confidence if I was going to remake this guy's smile. I won't tell you the entire process today because we just have an hour. But what I can tell you is some of the things that you should look for, some of the red flags that you should avoid, and how to get started if you were to get started on a case like this. And the other thing I always noticed is that 18 and 31 are just weird. 18 and 31 are weird freaking teeth. Like people break 18 and 31 all the time. I would say there's how many people on this call? 270 of you. I bet at least 50 of you are going to go to work tomorrow and see a patient who broke a cusp off of 18 or 31. And so you're like, oh, dude, you broke a cusp off of 18 or 31. Let me put a crown on that sucker. So you prep the crown and then you have them bite. And you're like, I took 2 millimeters. I took 2 millimeters off the occlusal. Like, why are you still biting? Like, why is that still in contact with the upper tooth? That's freaking weird. So what do? I flatten it out even more. And then I look and I'm like, that's freaking weird. This tooth now looks like a pancake. Now, fortunately, I'm going to make a real quick plug for you people at Kettenbach. Kettenbach cement, their Visalis Semcor cement, is a really nice cement to use when you do have a tooth that looks like a pancake. But what I will tell you is without a better understanding of centric relation, of occlusion, of how the muscles work and how the jaw works, a lot of times you're just going to find that 18 and 31 are just weird and they make working a little bit frustrating because you're not really sure how 18 and 31 are going to behave if you're going to restore those. Okay. I find manipulating a person into CR is very hard. And for a long time, I didn't really even know why I was doing it. And for a very long time, for the majority of my career, my go-to treatment for a patient experiencing pain would go something like this. I would make them a night guard, and I would adjust that night guard in maximum intercuspation. I wouldn't mess with their jaw, with their actual TMJ. I would just say, here, bite on this night guard. Okay, let me adjust it so that I see little dots all the way through. That's it. Okay. I would make them a night guard. I'd adjust it. And you know what? That usually worked. It worked a lot. It worked more than 50% of the time. And then if the systems didn't resolve, I would send them to a specialist. And I think, and I might be wrong, but I think amongst the people that are on this call, I think there's a lot of you who do just that. And what I want to tell you is you have nothing to be ashamed of. I think the vast majority of dentists do just this, and we're still offering our patients a really nice option. Because a night guard, just a night guard made by the least knowledgeable person, a night guard is still going to help reduce symptoms and help create a little bit more of a predictable bite. So even if you do this, that's excellent. But I want to see if we can get a little bit more knowledge.
So go ahead and open up wide. How often does it pop like that?
When I open wide,
Yeah.
or sometimes when I try to chew, when I go to bite or whatever,
Yeah.
I can bite, but it'll just make a popping or popping noise. Yeah.
Okay, so she pops. She pops. I go in there for a hygiene check. I have her open just so I can like pull her tongue out of the way, and I hear this like ping pong ball pop. And I'm like, okay, I got to do something. I got to be able to do something. Okay, so that's an obvious one. I could refer them to a TMJ specialist who will make them a nice, like a special, like a TMJ night guard, which is great. The TMJ specialist could equilibrate. Equilibration, I always, for a long time, thought was um, very difficult to understand. I'm hopefully going to give you a little bit of knowledge about that. The TMJ specialist might send them to a chiropractor or a physical therapist who might be able to manipulate the muscles even more. Or the TMJ specialist might be able to reconstruct the bite so that the way that she bites, now this part's important, the way that she bites allows for the position of the condyle to be in the healthiest position. So I want you to think about that. Right now, she looks like a pretty normal lady, and her bite looks like a normal bite. Here's my bite. Looks pretty normal. I mean, it just looks like a bite. But for some reason, her normal bite puts her condyle in a disharmonious or diseased position. That means that when she bites her teeth together, it's possible that a ligament, a muscle, a tendon is getting pulled. Maybe a portion of the cartilage that's sitting on top of the condyle is getting pulled in one direction or the other. Maybe that cartilage is completely off of the head of the condyle or something like that. But a lot of that could be due to her bite in maximum intercuspation. And so our goal is to say, all right, well, maybe there's something about maximum intercuspation that is causing a TMJ issue. Now, what else about maximum intercuspation? Here's somebody, no cavities, maybe a little bit of gum disease. They're in MI. They could have a tremendous amount of symptoms because they have quite an overbite, and that overbite might reduce some of the muscular mobility of their jaw. What about this person? This is a pretty young patient, and for some reason, they've already destroyed the enamel on their lower incisors. This patient was this patient clenches so hard that they were able to break a freaking tooth. Now, our enamel is supposed to be like diamond hard, and they were able to bite hard enough to split that enamel in half. There's something going on with the TMJ. Here's another patient who, over the years, has made it so that all of the pointy parts of their teeth, of his teeth, have now become unpointy, have become totally flat. And here's another patient. This is actually a very young patient. She's leaving to go to college next week. Um, she already has four little holes in her molar there. That is maximum intercuspation. Now, the reason, and I want to talk about maximum intercuspation here, because see, I would say the majority of us, if we see a mouth like this, the one that you see on the left of your screen, not really bothered too much. It's a pretty nice looking set of teeth. They're straight, they're white, they're solid, they're healthy, they're decay free, they're disease free. And so I think the majority of us would say, okay, well, let's just kind of leave things as is. But if we are going to maintain maximum intercuspation on this patient, and then they break a tooth, we're going to restore that tooth in MI. And then let's say over the years they break another tooth. We're going to restore that tooth in MI. Of course we have to. We restored the first one in MI. We're not going to all of a sudden change the rules. And so what's going to end up happening is as this person grows older, all of our restorations, and there's a lot of them here. What? One, two, three, four, five, six, seven, eight, nine by my count, nine indirect restorations in this patient's mouth, all restored in maximum intercuspation. Throughout the years of all the dentistry they had, there was never an opportunity to bring that person into centric relation and get that person in the healthiest jaw position as their mouth was being restored. What I would like to challenge you all to do is to at least introduce that idea. Okay? Now, I want to first tell you the people that I gained knowledge from who I actually thought were very effective, who were not condescending, who were very pragmatic. John Nasty, he runs a educational organization out of Dallas. It's called a Clinical Mastery. It's fantastic. For those of you who do want to jump headfirst into TMJ, that Clinical Mastery course is fantastic. The person in the middle here, this is Tony Tomorrow. He's also a Catapult educator. He was the lead educator at Las Vegas Institute for a long time. His knowledge base about TMJ is excellent. And then, before Dr. Dawson died, I had the pleasure of attending some of his courses down in St. Petersburg. I feel like the knowledge that I have about this is because of really smart people who I had the pleasure of listening to. And if you have an opportunity to listen to these guys speak, obviously to listen to the people who have taken on, who've continued Dr. Dawson's CE, and then of course, Tony and Dr. Nasty, take advantage of those CE because they're excellent and they're pragmatic, and I think you'll find them very useful. Okay, so let's get to it. In a perfect world, maximum intercuspation and centric occlusion should be the same. Okay, so that means that this is me, by the way. My occlusion when I bite my teeth together, and my occlusion when my jaw is in centric relation. Those should be the same. Okay, that's rare. There's not that many people that are like that. And if I manipulated myself into centric relation, I probably would have a very, very, very slight difference between MI and CO. But if it was perfect, they would be the same. I am asymptomatic, and so I don't care. I don't care that I have a slight difference between MI and CO because I am asymptomatic. Next, the next rule in a perfect world is that if a person is going into lateral obtrusive movement, here I'm lateral obtruding to the right, there should be no interference from any of my cusp tips on the left. If you see interference from any cusp tips on the left, that's a problem. It needs to be adjusted, okay? And if you notice here, my lateral obtrusive is in group function, and group function works fine for me. However, if I were to reconstruct, if this was a patient of mine and I were to reconstruct their bite, I would reconstruct their bite so that if they were in lateral obtrusive movement, I would only have guidance on the canines. The reason why is because that is established now as the lateral obtrusive guidance, which will lead to the best long-term longevity of your restorations, okay? But I don't have any restorations. I'm fine with my group function. However, if I was going to restore, I would restore with canine guidance, okay? Hopefully you're following me there. Next, when in protrusive, we need to have a tooth on either side of the midline that are in contact, okay? If I was in protrusive and tooth number 8 here was not in contact with my lower incisors, we would have a problem. And I think you would be amazed at how many of your patients have one-sided protrusive support, meaning they slide forward up the hill and only one side is touching. And no surprise there, that is the side where they are experiencing the greatest amount of enamel breakdown. This is something that often is very easy to fix. If you only have one side of support in protrusive, you just adjust some crap. Just adjust a little bit of the lowers or of the slope of the lingual of the uppers, and then make it so that they have equal protrusive support, okay? And then also in a perfect world, a patient can open big and not have pain when they are opening big. They can slide into both lateral obtrusive movements and protrusive movements without any pain. And the last thing is their enamel should be healthy. And what I mean by that, I'm 47. You can see that I've lost a little bit of the enamel on my canine here, but otherwise, my enamel is pretty healthy for my age as a 47-year-old. Okay. When you start to see 25-year-olds and they have pits all over their enamel, that's a problem. And that is probably due to some type of occlusal or TMJ issue. Okay. All right. So tomorrow you go in for a hygiene check. Okay. And the patient's fine. No cavities, no whatever. They're doing fine. But you see this. Okay. I want to tell you a couple of things that have been very helpful for me in having a conversation about TMJ. First of all, if you don't have an intraoral camera, dude, get a bunch of intraoral cameras. They're cheap. You can get an intraoral camera from Shofu or Mouthwatch that are like 250 bucks. Buy enough so that your hygiene rooms have them. There's no excuse today to not have IOCs. Everybody should have intraoral cameras. You walk in, you see this, grab the sucker and take a picture of it. Okay? And then I got this line from Dr. Nosti, and I say something like this. Okay, you see this? Your teeth are kind of like M&Ms. You have a hard shell on the outside, and then you have the chocolate inside. Okay? The hard shell is called enamel. The chocolate on the inside is called dentin. And I'm starting to see some chocolate. Oh, God, that is so effective. And the patient sees it, and they're like, oh, dude, there's the chocolate. And now the patient is going to be much more motivated to do something. Okay? The second thing that I would recommend is, and I want you to all try this right now. I want you to listen to me first. Stick your fingers in your ears, and then just open, close, and go in the lateral intrusive. Okay, let's do it together. Ready? Okay. Now, more than likely, all of you who did that, you felt some crazy, weird, gnarly ass pop or click or some. It's gross up there. I mean, it's like feeling that condyle as that condyle is manipulated in the fossa. There is a lot of potential for error. Okay. Now, I felt some clicking and popping, but again, remember, I have close to perfect world occlusion in that my lateral intrusive is healthy with no interference. My protrusive is healthy with no interference. I have mostly healthy enamel, and I have a large range of motion with no pain. Okay. But when you see a patient that looks like this, and you see that they're already losing a little bit of their hard candy shell, and then they stick their fingers in their ears and they're like, oh, dude, there's like a pretty significant click or pop or snap when I move to the right or move to the left. Now you have a patient who is taking a little bit more ownership over their long-term occlusal and temporomandibular health. Okay. Now, another thing that I sometimes say to patients is when I see this, but I didn't make mention of it 6 months ago, it probably was there 6 months ago, but I didn't make mention of it 6 months ago, I might say something like, you know, your teeth look a little different than last time. Here, let me take a picture and show you what I mean. And then I might have that M&M conversation. Or when I see this, and I have a patient who's still reluctant, and they're like, I mean, it's not hurting me. What's the problem? What I like to do is this, and I want you to try to be really disciplined here. As I say, okay, so Mr. Jones, you're 39, and you've already lost enough enamel where I can see the dentin underneath. What do you think is going to happen over the course of the next 30 years? Now I zip it. I just zip it. I don't say anything. And I let Mr. Jones articulate what he believes is probably going to happen over the next 30 years. And most of the time, if I follow these particular steps, I have a patient who has a little bit more of an inclination to take ownership over their TMJ health. And they might be a little bit more prone to saying yes to whatever I might recommend. Okay? Now, the conversation is much simpler when a patient has symptoms. If a patient says, yeah, I do have a little bit of limited range of motion, I have some pain, I do have a pretty significant pop when I try to eat a sandwich. Well, though, then it's like, okay, let's talk about your treatment options. And you're already going to have a patient who's going to be quite open and eager to getting started with treatment. Okay. So now they're interested. They're cool with you intervening. Now what? what I want to talk to you about is when to refer, how to determine CR, when and how to equilibrate, and when to mount in CR. Okay? So, when to refer. If a patient has pain that does not resolve after 2 to 3 weeks of Quicksplint therapy, they will probably need to be referred. Okay, I will tell you what Quicksplint therapy is in the next slide, but what I want to tell you right now is that if a patient does not have resolution or improvement in their pain after 2 to 3 weeks of Quicksplint, then you should probably allow somebody with greater TMJ knowledge to take over. The second thing I want to talk to you about is that when we open our mouths, we don't open our mouths straight up and down. We usually have a little bloop, in the way that we open. I think all of us learned that in occlusion class in dental school. But if a patient deflects and they stay on one side, meaning their jaw, their chin completely moves to one side or the other, there is more than likely a full displacement of the cartilage, of the disc that's sitting on top of their condyle. And that is a patient who you probably are going to want to refer. Okay? So one more time, pain that doesn't resolve or deflection. Those are the patients you want to refer. So let's talk about Quicksplint and what it is. Quicksplint is basically this very simple semi-lunar piece of plastic. That's all it is. This little ingenious thing is just a semi-lunar piece of plastic that I use pretty much on a daily basis, okay? Because I have a lot of conversations with patients about their TMJ health. So the way that you make a Quicksplint for a patient is you use a high quality bite registration. So Kettenbach makes a bite registration called Futar Bite. I am a firm believer, if you try Futar Bite, you'll never go back to Blue Moose. I've never met a dentist who's like, yeah, I tried Futar Bite, but I went back to Blue Moose. No, nobody ever does. If you try a Kettenbach bite registration material, you're not going to go back to Blue Moose because it's just better. So there it is. This is the lady who her mouth popped. I said, okay, let's just start you off with a Quicksplint. That was it. I just made her a Quicksplint. I grabbed that semi-lunar thing. I grabbed some Futar Bite, put the Futar Bite inside of that, had the patient bite down, and there she goes. She goes home with this Quicksplint. That's it. I'm noticing that in the chat, a lot of the people are like, yeah, this thing is so freaking useful. It's so simple and it's so useful. Okay. So this is what I tell my patient. I say, let's get you back in here in 2, 3 weeks. I want you to wear this as much as possible. Try to go to sleep with it. Try to wear it like when you're getting breakfast ready. Try to wear it when you're driving to work. And for show, wear it all the way to your next appointment. I want you to come in the morning, and I want you to wake up in the morning, brush your teeth, and then snap that sucker back in and wear it for the drive to my office, and wear it when you're sitting in the waiting room, and wear it when you're seated. Okay? That's very, very important. If you're going to make a patient a Quicksplint and you're going to do further treatment, which is what most people do, hey, Lisa and Ryan, Emily Skibinski is asking what the code is for Quicksplint. I don't think my office does it right because we actually work in the cost of a Quicksplint in their night guard, in their 9940 code. So if somebody could help answer Emily's question, that'd be helpful. Or if somebody else just knows. But I use the 9940 code, and basically the Quicksplint, the only time a person pays for a Quicksplint is when they don't get a night guard, ultimately. So anyway, this is the Quicksplint. A lot of you right now are asking about NTIs, and the answer is, dude, an NTI is expensive. A Quicksplint is cheap, and a Quicksplint is immediate. You give them, that's why it's called quick. You just give them the Quicksplint. Okay, let me tell you why it's beneficial. First of all, it's going to deprogram the TMJ. All of us, we have programmed our TMJ. Our joint is in the position that allows for maximum intercuspation. All of us have done that. That's why if I told you all to snap your teeth shut, you're going to snap your teeth shut in MI. So the reason that a Quicksplint is so nice is it deprograms that habit. It allows a patient to, oh, I didn't know Tony's on this call. Tony, what's up? Well, I wanted to, oh, so that's cool. You got the shout out. At least the Tony T that just used the comment, I'm wondering if that's Dr. Tomorrow. Anyway, it deprograms. So the importance of its deprogramming is it's going to allow you to do further treatment without that patient's muscles being completely habituated to MI. The second is it helps determine compliance. So what it does is if I make a person a quick splint and they come back 2 to 3 weeks later and I'm like, hey, how was it? And they're like, yeah, I never really wore it. I'm like, good. I'm glad to know this because I don't want to make you an expensive ass TMJ appliance when I know you're not even going to wear it. And so it helps determine if a patient's going to be compliant or not. The next way it is that it will help convince a patient that they need long-term intervention. Sometimes a patient will come back after 2 to 3 weeks of wearing the quick splint, and that thing is destroyed. It's like it's got cracks in it, it's got all these wear facets. And I'm like, look at this thing, man. Like you did this in 2 to 3 weeks. Think about what you've done to your teeth over a lifetime. And the other reason that it's a nice way to convince patients is because the patient's like, yeah, I've been wearing this thing and I feel a lot less pressure, my headaches are gone away, etc. It's a very low cost way without them having to commit to a night guard. It allows them to realize the importance of some type of TMJ intervention. And then, of course, the last one is if a patient's in pain right now, and I think one of you just typed that in, iPad said, quick splint to occlude, they're not programmed, blah, 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 take care of symptoms. Yeah, okay, so iPad, you wrote something about this takes care of symptoms, but not the cause. You're right. I agree with you. We'll get to the cause later. However, having a deprogrammed set of muscles definitely makes it easier to take care of the cause. Okay. But what's really nice though about the quick splint is a patient, they come in and they're in pain, you make them something right then and there, rather than having them wait 2 weeks for a night guard to be made. What time is it? 8:37. Cool. Okay. Now, the patient comes back 2 to 3 weeks later, and they're like, yeah, I feel a little bit better. I've been able to wear it. I like it. Some of my headaches have gone away, whatever. Maybe a patient says nothing. Maybe they're like, no, I don't have any symptom resolution, but I don't mind wearing this thing. And I'm still with you about wearing a night guard because I know that I'm wearing the crap out of my enamel. So I say, okay, now we have three choices. The patient is going to want to do some type of treatment and would be accompanied with ibuprofen to reduce the accompanying inflammation with TMJ. So Dr. Peter said, quick word of advice. This quick splint should be accompanied with ibuprofen every 6 hours to reduce the accompanying inflammation within the TMJ for a week. I apologize. Dr. Pater, you are correct. What we want to do is reduce the inflammation in the joint, and giving a person an anti-inflammatory is helpful. For those of you who are a little bit more hippie-ish like me, I like to recommend that people do turmeric or something like that, but ibuprofen is going to be effective. Now, patient comes back. They were able to wear their TMJ, their quick splint. What can we do? First, at this point, it's very easy to get a person to guide a person into centric relation. Okay. So if Millie had worn her quick splint for 2 weeks, I probably would have had better luck manipulating her jaw. I still don't like manipulating the jaw. I still feel like a clueless person who's acting like they know what they're doing when I manipulate the jaw. Okay. I would much rather use a leaf gauge to manipulate a person into CR, and I'll tell you how to use that in a second. Okay. The three interventions that you can do now is fabrication of a night guard. But in the fabrication of the night guard, you are going to send the lab a CR bite rather than a maximum intercuspation bite, so that the lab can fabricate that bite splint and allow that person to have support when in centric relation. Okay. All right. Sadia, Sabir, can they be used as permanent solution by constructing them again and again instead of Botox injections? You know, Dr. Sabir, I don't know much about Botox. I wish I did. I just wouldn't be a good resource for you when talking about Botox to treat TMJ. The second thing that you can do is you can try to equilibrate um, their uh, their occlusion so that you can create stops in the bite in centric relation so that their CR, so that their centric occlusion becomes their maximum intercuspation. This does require an articulator, in my experience. It does require mounting the case in CR, finding where the MI, the CR to MI interferences are, and eliminating those interferences through the use of reduction in the slopes of their teeth. And I am not going to talk about the details of that because I want today's lecture to just be the basics of, of, um, of occlusion and TMJ. But occlusal equilibration can be started at this point after the patient has been wearing their Quicksplint, and you can mount their case in centric relation. Or you can go all the way to the point where you can feel comfortable in starting the process of reconstruction, because now you can guide the patient in centric relation and you can start the process of waxing up the ideal dental arches in centric relation if you're going to reconstruct the bite. Okay. Now, why is centric relation so important? Hey, Lisa, Dr. Bandari is asking for this certificate. I believe the answer is, Dr. Bandari, you have to attend the entirety of the lecture, and you will be able to get the certificate once you are done attending the lecture. Okay. So why CR? Because maximum intercuspation led to their problems. Okay. My CR and my MI are not identical, but I don't have problems. So I am in no interest to try to guide myself into centric relation. But if I have a bunch of enamel that is missing, then if I have enamel that is missing, then that means that maximum intercuspation has led me down a road where I had problems. Does that make sense? Maximum intercuspation is so freaking convenient, and that's why we use it for the majority of cases. But when we have patients with symptoms, it's our responsibility to say, hey, part of having symptoms is the fact that your maximum intercuspation may not be the healthiest way for you to bite. Okay. iPad said that's called physiological adaptive range. I think what you're talking about is the little gap that I have between healthy MI and CR. Okay. So, so the MI led to this. So what I'm trying to do is see if I can get a patient back into centric relation, get them to a point where when they're occluding in centric occlusion. Okay. Lily said, why not continue to use an anterior deprogrammer as a long-term night guard if the patient has relief of symptoms? Oh, the only reason that I can't use a Quicksplint long-term is because it's not made out of very robust materials. It's a piece of plastic. It's cheap. And so that's why I need to ultimately make them a long-term night guard at that point. Okay. Why are those cusp tips flat but not flat but hollowed out? iPad, why are those cusp tips not flat but hollowed out? I feel like I see this all the time. I feel like it's just because dentin is weak or something. I don't know. But I feel like people who clench and grind their teeth, who have habitual bruxism, they have little holes in their teeth and they think they're cavities, but they're just the chocolate showing. Okay. All right. Now, why CR and how CR? Dr. Ramos said, what about using a D-Pass appliance? Remember, listen, I'm talking to you as the most bread and butter basic general dentist. I know for sure that, oh yeah, okay, everybody answered that question. I know for sure that there are appliances that are sophisticated. What I want to bring up to your attention though is the fact that that you can make them just a traditional night guard, but try to challenge yourself to make them a night guard that's going to guide them into CR. Okay. All right. So
Okay, now, um, have you been wearing this all night and all the way on your drive here to the office? Perfect. Okay, so I'm gonna go ahead and take it out. Okay. Yeah. So you can point to me when I'm talking, but then point back to you. Okay, so what I'm gonna do is I'm going to take a certain thickness here.
that's a leaf gate.
And I'm gonna have you bite, on it, slide forward, slide back, and then clench your teeth together. So look at me. You bite, slide hard, slide it out, and then clench. Okay? I want you to tell me if your back teeth touch when we do that. Okay? So go back,
Okay.
slide back, clench. Are any of your back teeth touching? Now, let me see. Okay, good. Okay.
So I continue doing that until I get to the point where she has her very first tooth in the back touch.
Let's record that. Stay still.
And then I use a very rigid bite registration like Futard D. Futard D is made by Kettenbaum.
And you're clenching, correct?
Now, if I were to mount somebody in centric relation, that's what I would do, is I would use a leaf gauge, I would go through that sequence. Now, I think a lot of you, if you were going to make a occlusal guard, you wouldn't get to the point where the back teeth are touching. You would actually have a little bit of a thicker amount of thickness in your leaf gauge so that you can actually have room for an actual night guard. However, the waiting until a tooth actually touches is quite helpful, especially if you're going to equilibrate. If you are going to mount these casts and you're going to on an articulator and you're going to equilibrate, it's nice to know where the very first point of contact is so that you can slowly start adjusting that person's occlusion to the point where you can get centric relation and centric occlusion and maximum intercuspation to slowly come closer together. Okay. So at this point, I'm able to attain CR. Now, why CR? Because it's the most stable orthopedic position. The muscles in CR are in harmony. The patient will have only one bite if they're in CR. And let's face it, you all know it. All the smart people in dentistry, they start with CR. You know, that we don't, the smart people, the ones that like teach all the classes and like have the most beautiful cases, they don't try to reconstruct people's bites in maximum intercuspation. And I have done that and I've made mistakes trying to reconstruct people's bites in MI. By the way, for those of you who jumped in about the acid erosion, you're totally right. I see it now. However, I know for sure that this patient has habitual bruxism. Okay, I'm still gonna make them a night guard. Okay, so if you have this patient who has evidence of enamel wear, I don't want you to just make them a night guard. I think you should also ask them what their sleep is like. Okay. Patients who clench and grind their teeth, 50% of them have some form of obstructive sleep apnea. People who grind their teeth, they are potentially grinding their teeth because they are, well, I don't know why they're grinding their teeth, but a symptom is the fact that they can't breathe when they sleep at night. Okay. One thing I would recommend you look into is something called the sleep image ring. This thing is only $300. And the sleep image ring is something that's very easy for a patient to take home. And it gives you a very good idea of whether or not they stop breathing. I took my sleep image home. I have 3 of these in my office. I took mine home. I printed out the results. My wife told me recently that she hears me snoring, and it turns out that over the course of the night, there were three times where I stopped breathing. One of those times that I stopped breathing for 42 seconds. So I might have mild sleep apnea, but I do have slight sleep apnea. I do. And I have sleep apnea, and that means that I probably should do something, whether I'm going to use a Deca laser on the back of my throat, whether I make myself a MAD, whatever it might be. Actually, Tony, let me hear. I want to read your comments because I always find them valuable. Regardless of your philosophy of occlusion, put your high speed in the holster and evaluate the occlusion so your restorative procedure does not contribute to more occlusal pathology. Also, be sure to cover all the teeth with your splint. If you use an anterior over time, the patient's posterior teeth will have the potential to hypererupt. Totally true. And then they grind their teeth in sleep apnea because they are moving their jaws in search of oxygen. Oh, that's why they're doing it. What I will tell you is that when you have those patients, if you have a sleep image ring, you are more than likely going to find that they have some type of sleep apnea. Okay. I have found that in more than 90% of my cases. Okay. And I'm going to skip over mandibular appliance. That's not relevant today's lecture. I am at 8:52. I want to briefly just talk about equilibration. I do not have the skills to equilibrate without using a Facebook and an articulator. A couple of rules of equilibration is if you're going to equilibrate, you're going to want to remove inclines rather than cusp tips in order to eventually attain their maximum intercuspation being close to centric occlusion. Okay. The other thing is, even if you don't feel comfortable messing with their occlusion, another nice way to equilibrate is just to achieve canine guidance or to at least achieve a balanced protrusive. So the whole, if you're going to equilibrate, first of all, take more courses than just this one. But remember, you can do a lot and see a lot if you mount a cast in CR, and you can see where some of those interferences exist. Okay. And then the last thing, reconstruction. I think a lot of you are going to see patients like this. In the next week, you're going to see a patient who looks like this. Maybe they haven't completely destroyed their occlusion like these first two. Maybe they just have a crazy overbite. And now all of a sudden, tooth number 12, yeah, I know we can't diagnose OSA, but we can definitely recommend that a patient see a doctor, and that patient will be eager to see a doctor if they have some type of documentable evidence that they have stopped breathing over the course of the night. So the one thing about reconstruction, this patient right over here, she needed endo buildup in crown right here on tooth number 12. I had an opportunity at that time to just do the endo, build the tooth up, and put a crown on it on tooth number 12, and I would have maintained her current occlusion. I asked her instead, I said, listen, if I make this crown, you're going to have the same occlusion as you always have. However, if I reconstruct your bite and give you an ideal bite, ideal occlusion, ideal jaw position, you're probably going to be able to keep your teeth a lot longer, and you're not going to have as many issues as you've been having. How do you feel about that? Sure enough, this patient wanted to do it. And so even though she needed endo buildup and crown on tooth number 12, I ultimately she became a full mouth reconstruction case in which we did a wax up, upper and lower, of the ideal bite in centric occlusion. Okay. That is the goal. Now, I'm not really I'm not going to teach you the steps for doing this. You got to take a longer course for that. But at least the next time you see a patient that looks like this, where you can't even see their lower teeth, and you got to restore one single tooth, at least have the conversation. At least have the conversation of reconstructing their bite so that they have a better long-term prognosis for their teeth, rather than just us fixing things in maximum intercuspation and watching them slowly fall apart. Okay. Now, I see that there is a argument that is occurring on the chat. And it sounds like there's a lot of people here that have more knowledge about TMJ than I do. And that's perfectly fine. I don't want to act like I know everything. But I definitely know something is that once I started instituting some of these changes, I've been able to reconstruct, do full mouth reconstruction with a lot more confidence. And I've been able to take patients who've had a lot of symptoms and relieve their symptoms just because I've been able to institute these small things. Understanding the importance of centric relation, understanding how to get a person in a centric relation, and understanding how that patient have that conversation. Okay, questions? We need to evaluate the use of plastic splints and other plastic appliances. They're swallowing microplastics. Lori, I think that you are making a great point. However, I can't speak about it. I would love to implement more myofunctional therapy, physiotherapy, but I can't talk about that. I can't talk much about that in this course, but I think you made a great point. iPad. Have you noticed the wear on the first slide is not flat but dished out? Oh, okay. So I think that that dished out occlusion, that patient has GERD. It's interesting because she's leaving to go to college in a couple of days. I'm going to talk to her about GERD. I'm going to tell her to go see a doctor about that. I know that she also grinds the crap out of her teeth. She's quite aware of it. So I'm still happy that I made her a night guard, but I'm glad that you all brought up the reflux issue. So thank you. Um, Gothic tracing, patient, instead of trying to manually guide the patient to CR. I'll tell you, I learned about the leaf gauge as a means of getting a patient into CR, and I found it helpful. Though I'm sure that Gothic tracing is also helpful. It's just my particular journey on how I learned. If you understand the principle of dentures, in which the provider has controls of dimension, centric, blah, 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 then full mouth reconstruction is simple. Okay, not a question, but I appreciate it. How do you determine the patient's unique vertical dimension? Okay, in terms of vertical dimension, when I'm talking about reconstruction, a lot of my vertical dimension is smile derived. Okay. That means that I want that patient to have, when they smile, to be able to show their top teeth from an aesthetic standpoint. I want them to, when they relax, that they still show a small bit of their top teeth. And I want them to have 1 to 2 millimeters of overbite and overjet. Now, think about those three rules: a smile that shows when they smile, a little bit of teeth that shows when they relax. So maybe I don't show mine. Maybe I need full mouth reconstruction. And 1 to 2 millimeters of overbite and overjet. That helps me determine their vertical dimension. Great question. iPad asked if I use a T-scan. I probably will eventually, but I don't right now. Patrice, how do I make a quick splint? Girl, oh, I shouldn't say girl. I say I'm very casual when I talk to people. It's the easiest thing. Dude, I've called you girl and dude now. Okay. Friend, doctor, just get some quick splints. You literally pull the thing out, squirt some futar bite inside of it, put it in the patient's mouth, and have the patient bite down. You don't ask the patient to bite down in centric, just have them bite down. That's it. That's all you do for quick splint, and I'm sorry for addressing you in such a casual way. Do you ever recommend the Rockabato 6x6 exercises? Dr. Stone, Larry, I need to learn about those. I don't know what those are. Okay, another thing about acid erosion. The MAD appliance. I don't, I'm not a fan of using the MAD. However, I think that untreated sleep apnea is much more severe than, I think a person who has untreated sleep apnea, they could die. Whereas a patient who has untreated occlusal disease, they could, I don't know, have jaw pain. And so I'm still going to make a person a MAD or a Vivos appliance if they can't wear a CPAP. And so I still do it, though you have a total point in that it is moving a person away from CR. How can I use a leaf gauge to record a bite on a scanner? Okay, so Dr. Murray Donna Storm, if you're going to use a scanner, Kettenbach makes a clear a futar clear. Okay. So what you actually do is you're still going to squirt the bite registration in the back, but you'll be able to record the bite on the scanner because of Kettenbach's clear product. It's actually pretty nice. Futar clear is pretty helpful for a variety of reasons. Okay. Do you use CBCT imaging for these patients? You know, I have to be honest. I have my CBCT. I use it for implant planning, but I have a very difficult time understanding what I'm looking at when I look at the jaw. All I know is beaking. I don't really know what I'm looking for when I look at a three-dimensional jaw image with my CBCT. As a result, I don't find it as useful when I'm evaluating my jaw patients. That is subjective, not objective. Okay. If you were to make a permanent night guard, how do you decide which arch to make it on? Lily, I'll be honest with you. I make it 85% on the upper arch, and I don't have a lot of rhyme or reason. Um, I would say that patients who have a pretty tremendous overjet, it's hard to make them a one on the upper arch. I rather make it on the lower arch, but usually it's upper. Can you refer patients for an MRI for subluxation? Kavita, those are exactly when I refer a lot of my patients. I'm a general dentist and I'm not a TMJ specialist. I refer patients out all the time. I know what to look for, and a patient with subluxation, patients who have uh, uh, where the cartilage, where the disc is completely displaced, I refer those patients out. Okay. How about using the aqualizer for jaw pain? That's excellent. Aqualizer is excellent. I just find that the Quicksplint is, I don't know, also excellent. And so I use the Quicksplint more often. However, in the occasions where I've used an aqualizer, it's actually quite helpful. Okay, now I'm going to jump over to the chat and I'm just going to see if I can find any questions on the chat. How about using? Let's see. So when you fabricate a night guard in CR, you wouldn't necessarily have even bite on all the teeth, right? That was from Ji Young. Yeah, that's correct. But remember, Ji Young, have the patient wear the quick splint for a couple weeks before you do that. It just makes everything a lot easier. Is your full splint flat? Do you fabricate it on the upper or lower? Most of mine are on the upper, except when we have a huge overbite overjet issue, and my splint is flat. Luis Gallardo, where can I get the quick splint? That's from Kettenbach. That's where you can get some more information from Ryan. Good. Okay. I believe I got most of the questions. I do want to just end with just a comment myself. I do want to tell you all that lecturing about TMJ is incredibly intimidating. I feel like a lot of dentists treat TMJ similar to the way they treat their religion. And a lot of dentists, they disagree or they just know more or I want to tell you that even though there was a little bit of a healthy exchange that was happening in the chat, everybody who was on this call was actually quite respectful. Nobody was condescending, and I think that says a lot about this audience, this Catapult audience. You guys are just pretty cool. And lecturing about TMJ is usually it creates a fight, and I didn't see a lot of fighting, and so that was really appreciated. I hope a lot of you got something out of today's lecture. It's always a pleasure for me to lecture to a Catapult audience. There was 270 people on this, and there was a lot of interaction on the chat. So I just want to tell you I really appreciate it. I hope you found it helpful. So thank you all. Appreciate it, everyone, and have a great night.